Good day, my name is Zara Mendoza, and today we will be discussing psoriasis and eczema. This is my aim, and these are my objectives. Let's begin with psoriasis. Psoriasis is a chronic inflammatory papular squamous and immune-mediated skin disorder. It is a hyperproliferative disorder involving the complex cascade of inflammatory mediators, including T helper cell 1, interleukin 17, and interleukin 23. This inflammatory immune response attracts more immune cells to the skin, which release further cytokines and chemokines, which results in an escalated positive feedback loop to form psoriatic plaques. It affects approximately 1 to 8% of the world's population, affects both men and women equally, but occurs earlier in women. It can develop at any age with two peak incidences, ages 20 to 29 and 50 to 59 among women, and ages 30 to 39 and 60 to 69 among men. Psoriasis waxes and wanes during a patient's lifetime, and is often modified by treatment initiation and cessation, and a few spontaneous remissions. It often affects the elbows, knees, extensor limbs, and scalp, and less commonly the nails, ears, and umbilical region. There are several risk factors associated with psoriasis. The major risk factors are the first three. Family history. Approximately 60% of patients report a family history of psoriasis. The psoriasis locus on chromosome 6p21 is a major genetic source of susceptibility. Infections such as strep throat and other bacterial infections can also result in the goutte-type psoriasis, and trauma, such as a surgical scar or injection site, can result in the appearance of new psoriatic lesions known as the Kovner phenomenon. Other risk factors would include stress, cold weather, sun or hot weather, obesity, smoking and environmental smoke, alcohol use, and medications such as biologics, ACE inhibitors, corticosteroids, lithium, antimalarials, beta blockers, and NSAIDs. The diagnosis is usually clinical and based on the presence of typical erythematous scaly patches, papules, and plaques that are often pruritic and sometimes painful. Psoriasis occurs in several distinct clinical forms, and biopsy is rarely needed to confirm the diagnosis. The 9 categories used to describe psoriasis according to the American Academy of Dermatology include plaque, scalp, guttate, inverse, palmoplantar, erythrodermic, pustular, nail, and psoriatic arthritis. Plaque psoriasis accounts for 80% of patients with psoriasis. This is characterized by well-defined round or oval plaques that differ in size and often coalesce. Silvery scale with hyperpigmentation may be seen in patients with darker skin. Plaque psoriasis lesions occur on the extensor surfaces of the limbs, arms, trunk, scalp, and buttocks. On the picture on the right, we can see the appearance of the well-defined round or oval plaques that differ in size, and we can see where it coalesce on the truncal region. Plaque on the scalp that may be seen on the hairline around the ears. There is a thickness and the extent of the plaques may be variable, as seen in plaque psoriasis. And this is depicted by the image on the right-hand side showing the scalp psoriasis surrounding the hairline. Goutte psoriasis is a more common in patients younger than 30 years, and lesions are usually located on the trunk and extremities. It accounts for only 2% of psoriasis cases. The small round plaques resemble water drops. Goutte itself means like a water drop, and classically it is described as occurring after strep pharyngitis or other bacterial infections. The image on the right depicts the water droplet type appearance of goutte psoriasis. The term inverse refers to the fact that the distribution is not on the extensor surfaces but in areas of body folds when we talk about inverse psoriasis. It is found in the intertriginous areas of the axilla, groin, and inframammary and intergluteal folds. It can also be seen below the pannus and within the adipose folds in obese individuals. The lesions are flat and well demarcated and have little to no visible scale, as can be seen depicted in the image on the right. Erythrodermic psoriasis is characterized by widespread generalized erythema, and it's often associated with systemic symptoms, of which hospital admission may be required. It may develop slowly from long-standing psoriasis or appear abruptly in patients with mild psoriasis. Morphologically, it can have plaques and erythema, or the erythroderma can appear with the desquamation of pustular psoriasis. Pustular psoriasis comes in localized and generalized types. Distribution is flexural and anogenital. In the generalized type, the skin becomes fiery red as depicted here and tender, and the patient experiences constitutional signs and symptoms. The time course is within hours, where clusters of non-follicular pustules may appear in a generalized pattern, and these pustules coalesce within 1 day to form lakes of pus that dry and desquamate in sheets, as depicted in this picture. Nail psoriasis or psoriatic onychodystrophy occurs in 80 to 90% of patients with psoriasis over their lifetime. Fingernails tend to be more affected than toenails, and there's an abnormal nail plate growth which causes pitting and subungual hyperkeratosis and onycholysis. And here we see the depiction of the pitting. Psoriatic onychodystrophy is often resistant to treatment. Lastly, we'll look at psoriatic arthritis, which is an inflammatory seronegative spondyloarthropathy that presents as stiffness, pain, and swelling of the joints and surrounding soft tissue. Most patients have a polyarticular arthritis, and it usually starts about 10 years after psoriasis begins, but it's wise to note that not all presentations of psoriatic arthritis have a skin involvement. It commonly affects the hands, presenting with dactylitis as seen here with the sausage-type fingers and nails. Patients with psoriatic arthritis need to be treated earlier with systemic agents such as methotrexate and biologics. This is to prevent permanent joint damage and disability, and it's often done in conjunction with a rheumatologist. There are other common comorbidities that are associated with psoriasis, some of which would include depression, which can be prevalent in up to 60%, but it improves with the treatment of psoriasis. There is an immune-mediated inflammatory condition such as Crohn's disease and ulcerative colitis, malignancy, where there's an increased risk of lymphoma and squamous cell carcinoma in patients who use psoralen ultraviolet A treatments, and associations with metabolic syndrome and obesity and myocardial infarctions. Now, the disease severity is assessed with a grading system using the body surface area for psoriasis. A patient's palm with the fingers extended and abducted is approximately 1% of body surface area. It is categorized in terms of its severity, mild, moderate, and severe. Mild being up to 1 to 3%, moderate 3 to 10%, severe being greater than 10%. Patients with psoriatic arthritis may have limited skin involvement but require more aggressive systemic therapy, and as such they would be within the moderate to severe category. Now there's another severity scale that can be used, but it is usually used within a research setting, and this is the Psoriasis Area and Severity Index score. Treatment can be both non-pharmacologic and pharmacologic. Non-pharmacologic would include smoking cessation, avoiding or minimizing alcohol use, weight loss for obese patients, addressing depression and offering stress management techniques, and avoiding known precipitants. Pharmacologic, first line for mild to moderate disease would include your topical treatments, which can start off with the topical corticosteroids being applied twice daily. If that doesn't work, we can use topical vitamin D analogs or a combined treatment of both. And if that as well does not work, we can use the topical corticosteroids with topical retinoids and the calcineurin inhibitors for your more sensitive areas such as your face and skin folds. It's also of note that maintenance with weekend potent corticosteroid use with or without weekday topical vitamin D increases the likelihood of remission. Second line would be phototherapy, and this has been highly effective for widespread psoriasis or psoriasis not responding to topical therapy or more severe disease. This would include UV treatment with narrowband UVB, Cerulean UVA, targeted phototherapy, and a combination of systemic agents with UV-based therapy. Also of note, the Cerulean UVA is associated with an increased risk of squamous cell carcinoma as previously stated and must be used with caution in pregnancy. Corticosteroids can be classified according to its potency, from low potency, mid potency, high potency, and very high potency. It is important to note that we usually start off with the lowest potency topical corticosteroid that will bring about the desired effect in hope of reducing the side effects associated with their use. And the side effects would include burning of the skin, folliculitis, thinning of the hair, acne, stretch marks, rosacea, excessive hair growth, and Cushing's syndrome. For systemic therapy, this is employed when topical agents or phototherapy fails and in patients with moderate to severe psoriasis involving greater than 5% total body surface area. Baseline investigations would include a CBC, renal and hepatic functioning, TB screening, hepatitis and HIV serologies, vaccination status, and a pregnancy test for patients of childbearing age because of certain teratogenic effects of some medications. Now, this is a nice slide that highlights the drug, its class, and the side effects for some of the more commonly used systemic treatments. We will start with methotrexate. This is an inhibitor of folate biosynthesis, and it's the first-line treatment for moderate to severe plaque psoriasis and psoriatic arthritis. The side effects include hepatotoxicity, pulmonary fibrosis, and fetal malformations. Cyclosporin, which is an oral calcineurin inhibitor, is the first line for pustular or erythrodermic psoriasis, and the side effects include renal toxicity and hypertension. Acitretin is an oral retinoid, and it is the first-line treatment for chronic palmoplantar or pustular psoriasis in non-childbearing potential patients. The side effects include hepatotoxicity and hypertriglyceridemia. It's also a teratogenic medication that can remain in the body for up to 3 years after cessation. There are various biologic agents, such as the TNF inhibitors, monoclonal antibodies, and your phosphodiesterase inhibitor. They are the mainstay of treatment for moderate and severe psoriasis, but some of the major side effects associated with it would be serious infection, cytopenia, increased risk of autoimmune conditions, and malignancy. Now let's go on to eczema or atopic dermatitis. Now, eczema is the name given to a group of disorders that can cause inflammation of the skin, but for the purpose of this presentation, we will be discussing eczema as it relates to atopic dermatitis, which is the most common cause. The various different types of eczema would include the dyshydrotic eczema, lichen simplex chronicus, nummular eczema, seborrheic eczema, and stasis dermatitis. So eczema is a chronic and relapsing inflammatory skin disorder which is characterized by itching and inflamed skin that is triggered by the interplay of genetic, immunologic, and environmental factors. Worldwide prevalence in children is 15 to 20% and is increasing in industrialized nations. 60% of cases begin during the first year of life and 90% by 5 years of age. 1/3 will persist into adulthood. It is estimated that 2 to 3% of the adult population is affected. Strong familial tendency, especially if atopy is inherited from the maternal side. There is an association with elevated T helper 2 cytokine response, elevated serum immunoglobulin E, hyperstimulatory Langerhans cells, and defective cell-mediated immunity and loss-of-function mutation in filaggrin and epidermal barrier protein. The various risk factors associated with eczema would include age less than 5 years, a family history of eczema, allergic rhinitis, asthma, antihelminic treatment in utero, and active and passive exposure to smoke. The diagnosis, it's usually highlighted, or the hallmark of eczema is usually pruritus. It usually has an atopic triad, which is important for us to pick up in our consultation, which would include eczema, allergic rhinitis, and asthma. The primary lesions would include vesicles, scales, papules, and plaques, and secondary or sequential lesions would include linear excoriations from scratching, lichenification, which would be thickened skin with accentuation of skin lines, fissuring, and prurigo nodularis. Also post-inflammatory hyperpigmentation and follicular hyperaccentuation. Now these pictures, the one on the left above, depicts lichenification with the thickened skin. We see fissuring on the upper right and post-inflammatory hyperpigmentation. The distribution of eczema for infancy and children would include the face, flexural folds, antecubital and popliteal fossa, neck, wrists, and ankles. For adults, it tends to predominantly affect the hands, with an increasing prevalence with increasing age, as well as the mouth and eyelids. Here we see a child with eczema where the face is affected, and here we have the antecubital fossa affected. In adults, we see the neck affected, as well as the eyes, the nose, and even the mouth. The picture on the left depicts widespread severe eczema in a child with cirrhosis or just very extremely dry skin. And on the right, we see the acquired ichthyosis on a patient with eczema. And the ichthyosis is really this scaly, fish-like appearance that patients with severe eczema tend to exhibit. The first investigation to order for a patient with eczema, we need to know that this is a clinical diagnosis. Investigations that can be considered, however, will be allergy testing, IgE levels, and skin biopsy. Now, allergy testing may be beneficial in assisting the patient to avoid exacerbating allergens, as well as those whose dermatitis remain difficult to treat. Treatment would include the use of emollients, or if that doesn't work, we can use emollients on topical corticosteroids. And if there's any signs of infection of the lesions themselves, we can add on oral antibiotics. Now, emollients tend to improve the barriers of the skin, improving the symptoms of the itch and pain, and maintaining the moisture of the skin, thus decreasing exposure to bacteria and sensitizing agents. Adjunctive medications that can be used would include antihistamines and doxepine, which is a tricyclic antidepressant. The antihistamines help with the intense itching, and the doxepine can help in those patients who have a lot of sleep disturbances. For ongoing treatment, it can be divided into non-refractory and refractory. Non-refractory looks at chronic or relapsing disease. First line for that being emollients and continuous use of low to mid-potency topical corticosteroids. Adjunctive therapy can be with topical calcineurin inhibitors or topical crisaborole. For refractory chronic or relapsing disease, which is defined as the disease course of atopic dermatitis or eczema that is resistant to various forms of treatment. So those that are resistant to topical corticosteroids and topical calcineurin inhibitors may benefit from emollients and continuous use of high-potency topical corticosteroids. Those resistant to high-potency topical corticosteroids may benefit from emollient and UV light therapy and topical cool tar. Those resistant to topical therapy and UV light therapy may benefit from emollient and systemic immunosuppressive agents such as cyclosporin, azathioprine, methotrexate, and dupilumab. This is just a nice summary slide that compares eczema and psoriasis in a table form, most of which have been already covered throughout the course of the presentation, but it's a nice quick guide for us to look at and review for clinical practice. So this is the end of my presentation. Thank you for joining me, and please let me know if there are any questions that you have.